Good afternoon, everyone. My name is Tim Lenartowych, and I am the Director of Nursing and Health Policy with the Registered Nurses Association of Ontario. And it's very much my pleasure to welcome you to the first in a series of webinars regarding RNAO's recently released report, Mind the Safety Gap in Health System Transformation, Reclaiming the Role of the Registered Nurse. I'm also very pleased to be joined by Anastasia Harripaul-Yhap, who is a nursing policy analyst within our policy team. Anastasia and I will collaboratively be delivering the presentation and look forward to answering your questions. I also would like to share that RNAO's president, Carol Timmings, has unfortunately had to send her regrets. However, I am sure that she wishes that she could be here and will certainly, I'm sure, be involved in future offerings of the webinar as she is able to do so. So I'd like to begin by wishing everyone very much a happy Nursing Week. This is a very special time for nursing, and it's a great opportunity for us to be able to celebrate our profession and to celebrate the contributions that registered nurses, nurse practitioners, and nursing students make to health and health care. And the webinar today, just to give you a of housekeeping. So we will begin with a presentation, and then following that presentation, there will be an opportunity to ask questions. Now, we are expecting a number of participants on the webinar this evening, and because of that, we have muted the lines just so that we can ensure everyone can hear and to minimize background noise. We're going to ask to try to organize in the best way possible, having people provide their questions in the WebEx chat box, and we will get through as many as we possibly can. So just a reminder, if you could please, at any point during the presentation, if you think of a question and want to put it in the chat box, by all means, feel free to do so. Anastasia, did I miss anything in terms of any of the housekeeping notes?
You've gotten them all.
Perfect. And I'll also add as well that the webinar is being recorded, so the discussion that we have will be made available to others who are unable to join this evening. So it'd be helpful for us to begin to look at the nursing workforce profile within Ontario. So the largest share of the workforce are registered nurses. There's about 96,000 RNs who are working in nursing in Ontario. And we know from regulation that RNs are to care for any Ontarian, including those with complex needs, those with less predictability, and less stable environments. And then we have about 39,000 registered practical, and RPNs are prepared to care for those Ontarians with less complex needs, with predictability, and a stable environment. And then we have about 2,400 nurse practitioners, and they build and expand upon the RN competencies, and this includes things such as being able to admit patients, serving as the lead primary care provider, and attending roles in long-term care, just to name a few. And there are 4 specialties of the nurse practitioner role: primary health care, pediatrics, adult, and anesthesia. And it's important to recognize that all nurses do have a very important role to play within the system. However, the key is the appropriate utilization of it. So what do we know? RNAO very carefully and closely monitors nursing human resource trends and data. And we use data from the College of Nurses of Ontario. And this allows us to monitor trends in the nursing workforce over time and ensure that we are able to speak to facts based upon the evidence. And what we have seen is very concerning. Across sectors, between 2005 and 2014, we have seen the share of the nursing workforce held by RNs decrease across sectors. One perhaps exception being public health. Now, public health, as many of you likely are aware, that there is actually a legislated requirement for registered nurses to serve as public health nurses. And so that likely explains why there's been consistency within that sector. However, as the report that we are going to speak to you actually shows, is there has been a slight decrease in the number of public health nurse positions that certainly warrants further investigation. So the policy agenda in Ontario very much is about redesigning the health system around the needs of people. We want to optimize quality and outcomes and maximize the return on investment, very important objectives. And the government is aiming to do so by a shift of service to the community. Certainly we know that care, appropriate care within the community can be more cost effective. Can be the same, if not at times better quality of care and safety. And it's where people want to be. People want to receive care as close to home as possible. But because we're shifting care more and more into the community, and technology is very much allowing us to do that, we're also doing it at a time when we are seeing a changing demographic, and we're also looking at the effects of a long-standing historic reliance on illness-based care and a lack of addressing the many determinants of health. So this means an increase in comorbidities and chronic disease. So as we try to shift care into the community, this means the length of hospitalization is getting shorter. The complexity of the patients within hospitals is increasing, as well as the complexity of patients within community-term care is also increasing as there is earlier discharge. As well, we're looking at exciting enhancements to scopes of practice, including our RNs looking at independent prescribing. Those of you who were at RNAO's AGM last week would have heard the Minister of Health and Long-Term Care speaking about independent RN prescribing, and we're very excited about that. Also, we're looking at enhancing the NP scope of practice as well. And surely there is a need to enhance public health and primary care to be able to meet the objectives, the policy priorities, and really shifting a focus towards health. And while RNAO very much is in line and influencing much of the policy agenda, RNAO's ECHO report was influential in informing the Minister's Patients First discussion paper. We're very concerned that despite all of these different policy proposals that are calling for health system transformation, we don't have a provincial interprofessional health human resource plan. Where is it that we want to go within 1, 2, 5, 10, 15 plus years in terms of health human resources, looking at supply, distribution, utilization? And how does that align with population health needs as well as looking at the policy priorities for the system? So in absence of having this plan, some organizations are responding to budgetary constraints by replacing registered nurses with less qualified providers or making adjustments to the organizational models of nursing care delivery as very short-sighted attempts to drive efficiency. We've seen this before, and unfortunately nursing is erroneously regarded as low-hanging fruit. And there is a very strong challenge with this, and the challenge is that budgetary constraints are driving decision-making and not evidence, quality, safety, and optimal patient outcomes. That is a very, very strong concern and limitation. It absolutely is imperative that to achieve the vision put forward in Patients First, that it is evidence, quality, safety, and optimal outcomes that is driving decision-making. So, I mean, unfortunately, many of these headlines have surfaced where healthcare organizations have replaced registered nurses with less qualified providers. In any time that RNAO hears from members about experiences where RNs are being replaced, we always have a discussion with that member or members, and then we will reach out to the leadership of the organization. And we want to hear from the leadership and ensure that we are speaking from fact and have an accurate account of what is going on. We then analyze the situation, and we do speak out if there are concerns related to patient safety. As an organization that is very much grounded in evidence and the need for safe and quality and effective care, we do have an obligation to speak out in incidents where that is not happening, and we'll continue to do so. So some of the activities that RNAO has undertaken today, and I just need to really begin by thanking RNAO's members, because it really is the strength and the voice and the unity of members that is really moving so much of this work forward. And so a huge pat on the back to each of you. So our Stop RN Replacement Action Alert that I hope that many of you have had an opportunity to sign, review, and share with friends and colleagues. We have received over 19,000 responses to that. Calling for an interprofessional health human resource plan was a priority for our Queen's Park Day this year, and we also at that time called for a moratorium on nursing skill mix changes and a outright stop to fragmented care models. This has also been a priority for our Queen's Park on the Road. We've had a very active media and social media presence. And in 2015, at our AGM, so a year ago, we did announce that we were going to be undertaking work to address changes to nursing skill mix and organizational models of nursing care delivery. And I would like to thank the many voices within our membership that really drove and helped to guide this work. And I'm very pleased now to share what the fruition is of this work. But before I do that, I really want to remind everyone around what is RNAO's model for health system effectiveness. Well, to have an effective health system, we need to have optimal health outcomes for the users of the health system, Ontarians, people, the public. And we see 4 key pillars that are critical to advancing optimal health outcomes, and that includes evidence-based policy and practice, ensuring that decision-making is in alignment with evidence and knowledge, the full and expanded scope of practice utilization of all providers, and matching competencies, knowledge, and skill with patient need, interprofessional practice, and how we can all work together, but at the same time stressing the need for continuity of care and continuity of care provider. And then health human resources planning is another critical staple for achieving health system effectiveness. So this leads us to the report that RNAO released yesterday at a very successful Queen's Park event that was hosted by our immediate past president, Dr. Vanessa Burkowski, and RNAO CEO, Dr. Doris Grinspun, and it was moderated by Marian Zich, RNAO's Director of Communications. At the media event, we did have representatives of the media. We had members, we had nursing students, and it was also attended by representatives of the government as well as representatives of the opposition. And we were also pleased to have in attendance representatives of ONA. And so the report really is, it's a robust evidence-based document, and we analyzed nursing human resource trends with population health needs and health system priorities. And so we looked at where does the Ministry of Health and Long-Term Care want to go in terms of the policy priorities for the future of the health system, looking at what are the needs of Americans in terms of their health, and comparing that in terms of what the system priorities are, and then looking at trends in nursing human resources, looking directly at the data to ensure that we have a factual, evidence-based discussion and trying to understand, is there alignment or is there a disconnect between these three key priorities? And when we were looking at the nursing human resource trends, we found that they were very much inconsistent with population health needs and health system priority. And we reiterated our call for our urgent call for an interprofessional health human resource plan through a transparent, evidence-based, and engaged process. And now it's my privilege to walk you through some of the key elements of the report. In the report, we talk about an analysis that we did of the health system policy priorities that have been described by the Ministry of Health and Long-Term Care. We used 3 source documents for that, and that was the Patients First series that was released by Minister Hoskins in 2015. We did a thematic analysis, and for those of you who may be interested in more details on that analysis, it's actually included as an appendices to the report, and we extracted 4 key themes from that analysis. The first is reorienting the health system within community-based care as one of the objectives of the ministry. Increase public transparency, providing coordinated and integrated services that match population health needs, as well as monitoring health system performance and improving accountability. So these were the policy priorities that we saw as coming out very clearly within these documents in terms of the ministry's desire, in terms of where they want to move towards. And these are areas that RNAO agrees with in principle, that these are important aspects to strive towards, but it's critical that we have appropriate nursing utilization and that the nursing profession is engaged appropriately. And we see that there are 4 key priorities that nursing as a profession that we can offer to advance these policy objectives, the themes that we just described. And the first is appropriate nursing skill mix utilization, ensuring that skill mix distribution is in alignment with patient needs, with knowledge, competencies, and skills of the different nursing categories. Having organizational models of nursing care delivery that advance care continuity. Maximizing and expanding scopes of practice, ensuring that we align the knowledge, competencies, and skills of everyone with the needs of people, and also evidence-based practice. Now, Mind the Safety Gap focuses on the first 2 priorities, and that includes appropriate nursing skill mix utilization and organizational models of nursing care delivery that advance care continuity. The latter 2, in terms of scope of practice and evidence-based practice, those are captured in RNAO's many documents. For example, our submissions to the Health Professions Regulatory Advisory Council, both for RNs and NPs rather. And we talk about, for example, independent RN prescribing or looking at advancements to NP scope of practice through Bill 179. And then, and also looking at authorizing NPs to prescribe controlled substances and so on. So we've done a lot of work on that, and that's important work and needs to continue, but it is captured elsewhere. And as well with evidence-based practice, that is a hallmark and a staple of RNAO's International Affairs and Nursing Best Practice Guideline Program, and the accumulation of that work are solid clinical practice guidelines, healthy work environment guidelines, our stellar best practice spotlight organizations, the thousands of best practice champions out there, institutes, webinars, and it goes much further than that. I'm just touching the tip of the iceberg, but that work is captured there. So I would like to take a moment just to reflect on the importance of a shift towards health. So to date, there has been a lot of emphasis on illness-focused health system policy and priorities. And in order for us to shift from an illness focus to a true health system, and we use that word quite deliberately, health system, as opposed to just a healthcare system. A healthcare system is an integral part of a health system, but it is not the only part. And we do require system planning that captures robust public health services, and public health nurses are paramount and critical to that. And we talk specifically in the report about public health nursing, the role of public health nurses in schools as one illustration of the importance of public health nurses. Coordinated primary care services. NAO's position is that primary care should be the anchor of the health system, and that all of a person's needs should be coordinated within primary care. Of course, the social and environmental determinants of health, ensuring that we have progressive social policies such as access to housing, income, and appropriate social supports, environmental determinants of health, ensuring that we have clean air to breathe, clean water to drink, and health equity, and addressing health disparities. And effective nursing skill mix and organizational models of nursing care delivery are certainly enablers of a number of these priorities here as well, and there is a connection there. But this slide is meant to recognize that certainly the need for a health system and the importance that the community plays within that. So if you ask a nurse today, I think I'm quite confident that they would tell you that the complexity of the people, the families, the communities in which they are caring or providing service for, the complexity is increasing. And again, we've had an over-reliance on illness-based care and generally a lack of attention to the determinants of health. And in no way am I trying to diminish the great work that has been done by our partners in public health and in the broader social and environmental movements, which NAO is a part of. We're making great strides, but there's still a lot of work to go, and certainly the historical context that we are up against has been insufficient attention has been given to those things. And as a result, people have often comorbidities, chronic disease, very complex needs. At the same time, we have seen the share and the distribution of the nursing workforce change. So for example, the registered practical nurse share of the nursing workforce has risen from 21.5% of the nursing workforce in 2005 to 28.4% in 10 years. This is to keep in mind in parallel to a time when we have seen complexity of care needs significantly increase. At the same time, Ontario has the second lowest RN to population ratio in Canada. In Ontario, our ratio is 71.4 RNs per 10,000 people, and compared to the rest of Canada, it's 83.6. And again, keep in mind what is the trend in population health, and certainly that is that complexity of care is increasing. So I'm going to turn things over to Anastasia. Again, we're trying to ensure that this is an evidence-based discussion, and so we are speaking from peer-reviewed literature. And Anastasia can describe to you some of the impacts that happen when we replace RNs with less qualified providers.
Well, thank you, Tim. The evidence on nursing skill mix is very clear. When RNs placed with less qualified providers, this results in increased mortality, readmissions, adverse events, lengths of stay, and transfers of care. It's also decreased with continuity of care, quality, safety, and satisfaction. And we've listed just a few of the studies that we found in our evidence review to support these outcomes.
Great. So thanks, Anastasia. So in terms of, we talked about changes in skill mix, and then the other priority of Mind to the Safety Gap is looking at organizational models of nursing care delivery. And this is the how. How are we utilizing nurses? And that is the organizational model of care delivery. And these are two distinct concepts, but at the same time there is also a interconnectedness to them. And so we are seeing trends whereby there's a shift from total patient care, where one nurse, either an RN or an RPN, depending upon the patient's needs and complexity and stability, would provide the total care to a small group of patients, and unregulated providers would support the nurse with delegated tasks under supervision. But we're seeing a shift back to team models of nursing care delivery, whereby there's multiple providers, an RN, an RPN, unregulated care providers, and each of them is parceled out tasks and cares for a pool of patients. This is we're reverting our profession back to a task-based approach in doing so, and unfortunately what is lost is continuity, efficiency, safety, quality, and patient satisfaction. So primary nursing is where individual patients are assigned to the most appropriate nurse, whether again it be an RN or RPN depending upon that patient's needs, who acts as their primary nurse throughout the entire care process, providing all aspects of nursing care. So this is a model of total patient care whereby the same nurse, one nurse provides all of that a patient's needs, but primary nursing then also strives for consistency across the care journey. So as much as that primary nurse is scheduled, there is attempts to ensure that that nurse is attached to the consistent patients, and those consistent assignments are being made. And our research, our look into the research that is available shows this as the most effective means of ensuring continuity of care and care provider. And I'll turn things back over to Anastasia to walk you through some of the evidence that demonstrates the challenges and the concerns that we have with a functional or a team-based organizational model of nursing care delivery.
So in our evidence review, we did look at specific outcomes to the major models of nursing care delivery, and we found that functional or team-based models of care results in increased hospital-acquired infections, time spent in administrative tasks, fragmentation of units, hierarchical care teams, inequitable workloads, liability risk, and adverse events. They also result in less psychosocial care, clarity of or accountability, continuity of care and care provider, and productivity.
Great. Thanks, Anastasia. So now we've talked a bit about our process and what we found, and now I'm going to describe the recommendations. And following this, then we will have an opportunity to have some questions. So the first recommendation is that the Ministry of Health and Long-Term Care develop a provincial, evidence-based, interprofessional health human resource plan to align population health needs and the full and expanded scopes of practice for all regulated health professions with system priorities. We don't have that plan today. And in the absence of that plan, we're calling on the Ministry and LHINs to issue a moratorium on nursing skill mix changes until such a plan is completed. And that plan will help to align, ensure that there is alignment between the needs of people, the needs of the population, the competencies, knowledge, and skills of all health professionals, and where we want to go as a system, and what are the system priorities, and ensuring that there is alignment between that. As well, we are calling for LHINs to mandate that the use of organizational models of nursing care delivery that advance care continuity and avoid fragmented care. So as I mentioned before, total patient care and primary models of nursing care. We know from the evidence that team-based models are less effective, and there are actually significant safety concerns, and so we are calling for an outright stop to those models of care delivery. Now, earlier we talked about the rising complexity of care needs. Our analysis is showing that the desired role of a hospital is to care for those who are the sickest of the sick, those whose care needs are so complex that they cannot be managed within the community. Therefore, we're calling for the Ministry of Health and Long-Term Care to legislate an all-RN nursing workforce in acute care effective within 2 years for tertiary, quaternary, and cancer care centers. Under the Public Hospitals Act, these are referred to as Group A and Group D hospitals. By design, these facilities are meant to care for individuals with a highly complex needs and instability. Then, within 5 years, we are calling for this all-RN nursing workforce to apply to large community hospitals who are identified under hospital regulations as Group B. Often, these large community hospitals are delivering a high degree of specialized care as well. They often serve as referral centers for smaller community hospitals, and they often have affiliations with academic centers as well. Now, when I'm referring to an all-RN nursing workforce, we're referring to RNs who are working together with an increased number of nurse practitioners and clinical nurse specialists who are practicing to their full scope. Within the community, and specifically in home health care, we are requiring that the first home health care visit be completed by a registered nurse. This will allow the registered nurse to do a holistic and complete assessment of the client's care needs, and then develop a care plan, which could include assignment of the patient's total care needs either to an RN, to an RPN, or to an unregulated care provider, depending upon what that individual's needs are. As well, we're calling for the ministry, LHINs, and employers to eliminate all barriers and enable NPs to practice to their full scope. This includes the authorization to prescribe controlled substances, acting as the most responsible provider in all sectors, implementing their legislated authority to admit, treat, transfer, and discharge hospital inpatients, and utilizing fully the NP anesthesia role inclusive of interoperative care. The next recommendation pertains to long-term care homes, and this is looking at how do we strengthen the ability to deliver the highest quality resident care that we can. To achieve this, we're calling for 1 attending NP per 120 residents. We've already made gains in the province through our NAO's advocacy to establish and to fund attending nurse practitioner roles within the province. There are 70 that have been announced, and we're continuing to advocate for to ensure that we are able to have 1 attending NP per 120 residents. As well, we're advocating for a composition of the workforce to include 20% RNs, 25% RPNs, and 55% personal support workers within long-term care. And then the final recommendation is calling on LHINs to locate the 3,500 current CCAC care coordinators within primary care to provide health system care coordination and navigation, which are core functions of interprofessional primary care. Certainly we know that some of the highest performing health systems within the world have primary care as their anchor, and there is a large body of research that specifically proves the efficacy and the quality of care coordination that is provided by primary care-based registered nurses. And the way that we see this unfolding, and for a much more detailed and comprehensive analysis, I would refer you to RNAO's direct response to the Patients First discussion paper, which is available on our website, rnao.ca, but we're calling for the CCAC care coordinators to be employed by the LHIN, however, located within primary care through a secondment. So that concludes an overview of the report, and I would like to invite you all to download a copy. We've given you here the direct link. This page has the report available as well as the speaking notes from yesterday's media event. As we continue to develop resources that are supporting the report, we will have them available on the website as well. We also welcome to hear from you, and I've listed there our CEO's contact information as well as my own, and we would love to answer any questions that you have, and certainly the dialogue will continue beyond just the webinar today, and we're very receptive to hearing from you. We also issued a second phase of our action alert yesterday. So if you have already signed our Stop RN Replacement Action Alert, this is a different action alert. However, it is connected, but it's specifically in relationship to the Mind the Safety Gap report. And I would encourage you to take a look at that action alert and hope that you will sign on to that. As well, we encourage dialogue through social media regarding the report, and we are encouraging use of the hashtags Mind the Safety Gap as well as Stop RN Replacement. So that concludes our formal part of the presentation. At this time, we certainly will invite questions, and the way that we thought we would do this, just given that we have a number of participants on the line, is we are inviting discussion through the chat box. And so by all means now feel free to put your questions in there. And I'll look to Anastasia to start us off with the first question that we've received.
The first question we received is, what evidence is based in Ontario where RPNs are educated with a diploma? And that's a really good question. So when we were doing the evidence review, we looked internationally to find the best evidence from the best researchers. But we also had research by authors from Ontario. So one that jumps out for me is Andrea Bowman. We have some of her work in our report. But we did look at comparable OECD countries where they have similar classes of nurses.
Yeah. Thanks, Anastasia. And I just want to reinforce that point as well, that we did have access to research that was conducted within Ontario, research and evaluation. And also we were very deliberate in reviewing evidence that was comparable to the health system within Ontario. Are there any other questions that people have? We recognize that with the report being so fresh and new, having been released yesterday, although the genesis has been coming for a year, so those of you who are at our 2015 AGM would have known that we had made the announcement that we were going to do work, and of course it's accumulated with the release yesterday. So it looks like someone has provided a comment as well as a question. So we're just going to pull that up. So the person's comment is, great report and presentation. Many of the recommendations remind us of recommendations that were made over 20 years ago, and some progress had been made, but then were set back. How can we prevent this from occurring in the future? Thank you very much for your feedback, and we really do appreciate your participation on the line tonight. You're right. Certainly we have seen cyclical changes within our profession, and it's very unfortunate that this happens, whereby we encounter experiences where budgets begin to get tight and decisions are made based upon the bottom line and not necessarily within the best interest in patient safety. continuity of care and continuity of care provider. So in terms of what we can do this time, well, certainly disseminate, share, use this report widely. Our NAO is staying on top of this issue, and you can certainly count on us to continue to be your advocate at whether it be with the ministry, with opposition, with LINs, and so on. We are going to continue to champion this issue. Get involved where you can. We have our Take Your MPP to Work event that is currently ongoing. We have our Queen's Park Day and our Queen's Park on the Road events. Absolutely get involved in those events and speak to your experiences in relationship to the report, because we have approached this very much from a expert policy analysis and informed by the voices of members, but it always is very helpful when there are illustrations directly from RNs, NPs, nursing students who are practicing, and the impact that ineffective skill mix and models of care decisions are having on the impact on patient care. So that's, get involved, and feel free to also disseminate the action alert that we issued yesterday.
So we have some more questions. The next one is, I am more concerned about the fact that the frontline worker in the community is the PSW rather than the use of RPNs in the hospital. Is RNAO going to provide leadership here?
So thank you very much for that comment, and certainly this report is not meant to be hospital specific, and we do address that the complexity of care is rising within the community, and people are being discharged sooner, as I'm sure the person who put this question knows, because I'm sure they're intimately familiar with the sector. And technology is making it so that people's needs can be managed within the community, and certainly this does demand a highly knowledgeable, skilled workforce to respond to those needs. And so one of the recommendations within the report is around ensuring that that there is an RN who is able to do an assessment of that individual and to identify a care plan based upon that individual's needs. So if they need care from an RN, that they would get care from an RN, or if they need care from an RPN or PSW, that they would also have access to that as well. So I think that's a really important point around the complexity of the care in the community, and that we need to ensure that we have the workforce that's available to respond to people's needs. Otherwise, there's a risk then that the people, that clients will be readmitted to hospital, or that they can't stay well within the community, which we want people to be able to thrive in the community.
And our next question is, are we advocating for an all-RN staff in the community hospitals due to the anticipated increase in acuity? Many of our community hospitals have had RPNs for decades. What size community hospitals are we talking about?
So great question, and thank you for it. So RNAO is advocating within 5 years to have the legislative requirement for an all-RN workforce to apply large community hospitals. Large community hospitals are referred to as Group B hospitals in regulation under the Public Hospitals Act, and this refers to community hospitals that have greater than 100 beds. And within the Mind the Safety Gap report, there is an appendices that actually lists out what is a Group A, what is a Group B, what is a Group D hospital, and so you can look in that appendices and see specific hospitals. And we pull that directly from regulations under the Public Hospitals Act. And absolutely, we are, the ministry's vision for hospital care is that it would be reserved for those who are the sickest of the sick and who have the most complex needs. And so from a patient care safety perspective and wanting to align the needs of people with the resources available, that is certainly what has motivated this recommendation to ensure that hospitals, these large community hospitals, quaternary, tertiary, and cancer centers are able to effectively respond to the needs of the users of that service.
And just to add to Tim's comments, the appendix starts on page 55, and To give you a better sense of what type of hospital is included, it actually does list specific organizations' names. And so our next question is, can you clarify where in primary care you see the relocation of the CCAC care coordinators?
Sure. So I think this is a really great question. And so I would first, for anyone who is interested in learning more about RNAO's position on care coordination, I would encourage you to take a look at RNAO's Enhancing Community Care for Ontarians model. We are currently in our 2.0 edition, and that was released in 2014, and it was originally released version 1.0 in 2012. And so this policy paper really has been influencing the agenda and has resulted in some of the most recent changes that have been discussed by Minister Hoskins. And then there's another document which is looking at RNAO's response to Patients First. And that's all available on our website. And that provides a much more detailed description in terms of how we envision the rollout of primary care coordinators, RNs who are coordinating care within primary care, including a sample role description as well as a sample process flow map. But just to give a little bit more meat to the on the bone here, we see the care coordinators as being employed by the LHIN, but through a secondment located within a primary care setting. And when I say primary care setting, I'm referring to interprofessional models of primary care. So, for example, nurse practitioner-led clinics, family health teams, community health centers, and Aboriginal health access centers. We also see the development of primary care networks, and this would help to, without trying to sound too jargony, this would help to achieve a horizontal primary care integration, because right now within the primary care setting we have a number of different primary care entities. We have FINS, FIGs, FOs, FITs, NPLC, CHCs, Northern Rural physicians, and so on. And we want to be able to improve access to interprofessional care, primary care, and so these primary care networks would be central to that, whereby connections are made between the interprofessional models and some of those solo and group practices, so that those patients can have access to care coordinators as well. And that's very much, this is the Coles Notes version of that, and there is a much more in-depth discussion of that within those documents that I mentioned, and I would refer you to our website for more details. Also, my contact information is available, so if you want to chat in more depth, I'd be happy to do that.
So our next question is, how can we maintain harmony between NP, RN, and physicians when nurses are able to prescribe controlled substances?
Okay, so just to clarify, so RNAO's position is we're advocating for nurse practitioners to be able to prescribe controlled substances. In 2013, there were federal barriers that prevented nurse practitioners from prescribing controlled substances under the Controlled Drugs and Substances Act. Those were actually lifted federally in 2013. And since that time, we unfortunately have not seen complementary regulations changed within Ontario to enable NPs to prescribe controlled substances. So these are regulations that need to be changed under the Nursing Act. In 2013, the Premier of Ontario, Kathleen Wynne, did announce that interested in looking at this issue, and Minister Hoskins at RNAO's AGM this year also spoke about how he's going to look at this. And so this is going to be something RNAO will continue to advocate for. I think it's incredibly salient given the role of nurse practitioners in offering end-of-life care, in supporting our LGBT communities, so for example, supporting trans persons who may be undergoing hormonal therapies, in supporting harm reduction. Those who were at RNAO's AGM most recently, we had May Cat. May is a nurse practitioner who provides treatment for opiate addictions within remote First Nations community. She does so through a multi-pronged approach, but uses Suboxone. And currently, Suboxone being a controlled substance, nurse practitioners don't have the authority to prescribe that, which is very limited from a harm reduction approach. And then also taking into account recent legislative proposals at the federal level under Bill C-14, which is the Medical Assistance in Dying federal bill. It actually would authorize nurse practitioners to provide medical assistance in dying. However, that can't happen in Ontario unless, of course, there's access to being able to prescribe controlled substances, or certainly it would be significantly hampered by that inability. So just to clarify, the controlled substance piece is for nurse practitioners. Now, for RNs, we are calling for independent RN prescribing, and this is within the scope of the registered nurse, and this is looking at opportunities right now to improve timely access to health services. So these are often those situations where, as an RN, it's the if only I could prescribe. And just to give you a few examples to illustrate a point, these aren't the full a comprehensive view, but for example, a patient spikes a fever in the middle of the night and needs Tylenol, or a resident in a long-term care home has a uncomplicated urinary tract infection, or a client within a public health unit requires hormonal contraception. These are just some of the examples. We are calling for a interprofessional course be developed where registered nurses and others could learn to ensure that they have the education to effectively prescribe. And we also see it as a continuum, so that would also authorize NPs to be able to communicate a diagnosis and order and initiate laboratory testing, because, for example, I gave the example before of a uncomplicated urinary tract infection. If the RN doesn't have the ability to interpret and initiate that testing, then it's just going to result in disruptions to continuity of care and isn't the best use of health system resources. So this is a role that is different and distinct from that of a nurse practitioner. A nurse practitioner attends school for a longer period of time, has a much broader role, and one example is going back to controlled substances. This is something that we're just advocating for NPs to prescribe. And in terms of looking at, Harmony is being used, it's about aligning the knowledge, skill, and competencies of the interprofessional team to ensure that we're utilizing those competencies, knowledges, and skills in the ways that best meet patients' timely access to care, quality, safety, and effectiveness. And really, if we ground our decision-making within evidence and within patients' needs, certainly at the end of the day it is we all win and benefit from that, but certainly there is enough work for all of us to go around. So thank you. So I'm noticing that we have about 5 minutes left. So maybe we'll take one more question, and then I know that there are some others, and what I can commit to is that we will follow up with the individuals who have provided these questions to ensure that we're able to provide a response. So the next question is, does this report take into account the legislative requirements for RNs within long-term care? Are the recommendations in the report aligned with these requirements? So the report does recognize that there is under regulation, there are requirements for RNs within long-term care, but we actually take it to the next level, and we want to ensure that residents have access to care from RNs, from RPNs, and from personal support workers. And the reality right now, and long-term care can attest, is that you may have one RN for 200 plus residents, and certainly we do not see that as being sufficient. And so we're calling for legislative staffing standards that would actually require the workforce to be 20% RNs, 25% RPNs, and 55% personal support workers, and see that as being a very key solution to improving access to high-quality resident care. So that being said, it looks like we have a couple minutes here, so I think we're going to wrap up, and we will get to those questions and reach out to the individuals who've provided those questions, the remaining ones, and my apologies that we weren't able to get to them. But I think that what tonight really represents is it's an opportunity for us to be able to present the report to members, to begin to explore it in more depth, and to really initiate a discussion about where do we go from here. And that's really what we want to continue to have happen. This is going to be the first in a series of webinars. Anastasia, what is the date for our next webinar?
Our next webinar will be on May 24th over the lunch hour from 12 to 1 p.m.
Great, and so anyone who has participated in this webinar is welcome to come to that one. Just to let you know, you're probably going to hear me go through the same presentation at the beginning, but if you don't mind that, we certainly would welcome you to come on board. If you have other new questions or you've had some time to reflect on the report, we'd be happy to have that discussion with you at that time. As I mentioned at the beginning of the webinar, this is being recorded, and so we will post it online for if you have colleagues who are unable to attend and may be interested, they can access it that way. And of course, and I think what we'll do is we'll actually put a link under the web site, the Mind the Safety Gap website, and the link that we provided to you in the presentation. If you go there, we will have a link to the webinar so that you can kind of have a one-stop shop for that. So in closing, on behalf of Anastasia and myself, we very much thank you for participating on the webinar. We wish you a very happy Nursing Week and hope that you will take time to celebrate your contributions to this amazing profession that we have. And thank you all for the incredible work that you do day in and day out. And we wish you the best. So take care, everyone, and have a lovely evening. Bye for now.